Very good afternoon to everyone. I think at the outset, I would like to thank Dr. Sarachandra for inviting me to give this topic or lecture. And I think good afternoon, everyone. Dr. Imad Shiban is there. Can I hear you?
Yes, we can hear you.
Yeah.
we
Yeah,
can.
I think, I think you also been here to my center here for doing the complex bifurcation lesions. So today's right away I would like to start, and nice thank you, Dr. Imad, and I welcome and to all the moderators, Dr. Brian Pinto and others. So my topic is today's switching of antiplatelet therapy. We know that DAPT is the cornerstone of management after especially the PCI, and we have now the potent antiplatelet agents like ticagrelor and prasugrel. So at the based on the some clinical risk factors, clinical.
Can you share the
yeah. So let's look at the first case scenario one, which we generally see in our.
We are not seeing your slides, Srinivas.
Yeah. Okay.
Fine. We see you.
Yeah. So now let's look at a clinical scenario. It's a 59-year-old male patient who is hypertensive and having angina for last 1 year, and he had acute chest pain for 48 hours. You can see the ECG. There was mild ST depression in the inferior chest leads, and troponin is positive. And this patient, you do an angio, he has got a osteal disease in the branches in LAD, LCX, and ramus, and then LCX is near total occlusion, and there is a bifurcation disease in LAD D1, and you have a RCA, a diffuse disease from proximal to distal. So it's a complex multi-vessel disease with a high risk syntax score. And he underwent a PCI to both RCA with 2 drug-eluting stents and trifurcation stenting, mini crush and tap CT technique for DES. So he underwent a 5 DES here. So he has got a 7 drug-eluting stents implanted. So we know that the patient characteristics which are related to stent thrombosis, you can see from this slide that antiplatelet therapy at discharge is one of the most important, which would determine the stent thrombosis and the long-term outcomes. So from the various studies from the Nordic, Cactus, and BBC, one study you can see the rate of stent thrombosis. If you do this bifurcation, various technique would be at least up to more than 2%, and in this case, in trifurcation, it would be even more than that. So this patient, we are given loading dose of ecosprin 325, prasugrel 60, and a maintained dose of ecosprin 150 and prasugrel 10 milligram. So how long the duration of this has to be given, when to switch, and which antiplatelet therapy has to be the next. This is a 60-year-old male patient, hypertensive, 4 years, with chest pain for 4 hours, EKG showing RBB with ST elevation, MI with mild reduced ejection fraction. And this patient has got a osteal LAD cutoff acute anterior MI. He undergoes a PCI to LM2 LAD crossover stenting, and this you can see there is a TIMI 1 flow because ACS anterior MI, TIMI 2 flow in LAD. So he was given a loading dose of ecosprin 325 and prasugrel 60, and maintained dose of ecosprin 150 and prasugrel 10. And he develops a bleeding the next day with hemoptysis and hematuria. So what is the next antiplatelet treatment strategy? This is a third case scenario where a 73-year-old male patient, hypertensive, reformed smoker, who had a left hemiparesis in 2015 with a near normal recovery of neurological deficit, but still persisting. He had chest pain with inferior valve diagnosis. This patient had a borderline disease in proximal to mid LAD, and mid LAD at the bifurcation there's a stenosis, and you can see here RCA there was a mid LAD thrombotic acute thrombotic occlusion. He undergoes a PCI to LAD with a large stent 4 size, and it was post dilated 4 and 4.5. So you can see the second day evening this patient developed this ECG changes. The patient had a VT which was cardioversion was done. I knew this diagnosis. This patient was given loading dose 325 and ticagrelor 180 with a maintenance dose of 150, and clopidogrel 70 was given in view of his past CVA and elderly age. But this patient developed a stent thrombosis. What would be your next antiplatelet treatment strategy? So the various reasons for switching of antiplatelet therapy are high risk coronary stent thrombosis, high bleeding risk, concurrent treatment with anticoagulation, intolerance to drugs like ticagrelor can cause dyspnea, decision for medical management or cost or financial issues, and drug interactions. So when you look at the patient, we have to determine how to choose your antiplatelet therapy. So you have to determine whether there is increased ischemic risk or increased bleeding risk. You have some factors where you can have both, like advanced diabetes, CKD, where you have both increased and ischemic risk. But pertinent to increased ischemic risk are ACS presentation, multi-vessel stenting, and complex interventions. For the increased bleeding risk, you have female sex, low body weight, past history of bleeds, anemia, or steroid use. Now, looking at the timing of ischemic events versus bleeding after an index event, you can see in the first 24 hours, you have increased both ischemic and bleeding risk, but towards over a 1 month period, you have the ischemic event coming up and the bleeding events are coming, but it will be slightly higher in the next 12 months. So looking at the pharmacological properties of these various new, all the antiplatelets which are available in our armamentarium, you can see this clopidogrel and prasugrel are the prodrugs and irreversible. The ticagrelor and cangrelor are reversible. And they have got a clopidogrel has got a half-life of active metabolite 30 minutes, and prasugrel has a different type of distribution and elimination half-life. And the onset of action is 2 to 8 hours for clopidogrel and 30 to 40 minutes for prasugrel and ticagrelor. And based on the prasugrel potent inhibition, it has got offset action is 7 to 10 days with no drug interactions. So looking at the mechanism, basically these drugs act on the P2Y2 receptor at this inhibition site, where it prevents the coupling of the G protein coupled receptors through CAMP and VASP related pathways to inhibit the platelet aggregation. So looking from the data from the pharmacodynamic studies, we can see from this recovery trial, the patients who are returning from baseline platelet reactivity after giving prasugrel clopidogrel, you can see over the 9th day, they have got the platelet reactivity is completely recovered after administration of prasugrel or clopidogrel. Similarly, for the onset and offset study, the platelet aggregation study, you can see the offset after the initial onset on the day of administration or the 10th day, it decreases completely. So how do we switch between the P2Y2 receptor inhibitors? So because we have to understand the potential for drug-drug interactions. So we define this as from the index event, if you switch within 24 hours, it's acute. Early, if in 1 to 30 days, late more than 30 days to 1 year, and very late more than 1 year. So the terminology for this pharmacodynamic switching is called escalation. When you do from say like we have the clopidogrel and prasugrel thienopyridine derivatives, and the ticagrelor is the cyclopentyl thiazolopyridine derivative. So when you have change between thiropyridine, it's called the intraclass, and if you change it to other thing, it's called interclass. So basically, when you have these changes, it's called escalation. If you go from clopidogrel to prasugrel ticagrelor, de-escalation prasugrel ticagrelor to clopidogrel, and change if you change between prasugrel and ticagrelor. So you have a drug-drug interaction when you go from ticagrelor to either clopidogrel or prasugrel. So the bridge is the terminology when we use when I switch for clopidogrel to oral to IV, the cangrelor or any of these class. And transition is when you, especially when you do for bridges, when you do for non-cardiac surgeries. Transition is when you do patient peri-PCA period, you give cangrelor and you have to change it to oral antiplatelet agent, then it's called transition. So what are the various studies on P2Y2 receptor inhibition on escalation therapy? The Plateau trial, which has been well studied, and it's shown superiority of ticagrelor or clopidogrel in reducing ischemic events. Over this, 50% of the patients were already given a loading dose of clopidogrel. In the Atlantic trial, ticagrelor was found to be safe, but no improvement on the pre-PCA coronary reperfusion. In the Pegasus trial, which has been studied in patients who suffered an acute MI within the past 1 to 3 years, the safety of ticagrelor was well studied with a maintained dose of ticagrelor either 60 BD or 90 BD, and 1/3 of the patient already have received a loading dose of clopidogrel in this trial. So overall, you can see from our clinical practice, from escalation from clopidogrel to prasugrel ticagrelor is seen in 5 to 50% of the patients. What are the studies on de-escalation therapy? So we have two RCTs, that's a tropical ACS and the topic trial. The topic trial was a single center trial where they found that the tropical ACS was the platelet function guided trial, which was found it was non-inferior to the control trial. But the under this tropic trial, where it was a single center trial, although they did not, it was a bleeding benefit, but they didn't report the stent thrombosis, myocardial infarction. The other two were the registries where the non-adverse cardiac events were increased. So overall, in hospital, de-escalation of therapy is seen in 5 to 14%, and out of the hospital, around 5 to 8% of the patients. So how to switch between these two? So it is to make it simpler. When you are escalating from clopidogrel to prasugrel ticagrelor, you just give a loading dose irrespective of the timing and dosing of clopidogrel. But when you are giving this is in the acute and early phase. So similarly, even coming from ticagrelor to clopidogrel, prasugrel to clopidogrel, or between switch between prasugrel and ticagrelor, you have to give the loading dose. But in these cases, it is 24 hours as the last dose. For the clopidogrel, irrespective of the dose. For the others, it is 24 hours as the last dose. For the late or very late phase, it is slightly different. So when you are switching, escalating from clopidogrel to prasugrel or ticagrelor, you have to give straight away the maintenance doses of 24 hours the last clopidogrel dose. Whereas if you are doing from ticagrelor to prasugrel or ticagrelor to clopidogrel, where you find drug interactions, you have to give a loading dose 24 hours of the last dose. So what does the ECS guidelines say? So in patients with ACS who were previously exposed to clopidogrel, switching to clopidogrel to ticagrelor is recommended after hospital administration with a loading dose of 180 milligrams irrespective of timing and loading dose. This has got a class 1 indication. So others all which are shown earlier is class 2 indication between switching between the oral P2Y2 inhibitors. So while then what is the bridging from oral to intravenous agents? So when you're bridging for non-cardiac surgeries, you have to stop the prasugrel at least 7 days before and ticagrelor and clopidogrel 5 days before, and start cangrelor to be infusion at 0.75 microgram per kg minute, no bolus up to 48 hours and maximum 7 days. Then stop cangrelor here and do a surgery and resume resume with clopidogrel, which is the ideal, and the prasugrel and ticagrelor at this phase is discouraged. So while transition in the peri-PCI period, when you are transition from intravenous cangrelor to oral P2Y inhibitors, so this clopidogrel has to be given 600 milligram immediately after discontinuous of cangrelor. Similarly, prasugrel loading dose. But for ticagrelor, you have to give at least 180 milligram at the starting of cangrelor infusion. So let's see from this knowledge what you have gained so far, which have given some overview. You can see from this case, this is the first case where you had a multi-vessel stenting, complex intervention, multiple stent. This is the check angiogram after 1 year of this patient. You know, all the stents are patent, all are doing well. So you are on. So after 1 year, this patient was put on maintained dose of ecosprin and clopidogrel 75 milligram, and this patient has completed almost a 3 years follow-up. The patient is doing fine. In the second case, where there was acute MI with ostial LAD cutoff with acute thrombotic occlusion, LM to LAD stent, he had a bleeding. So we had to change it to, in de-escalation, we have to change it directly to a maintenance dose. So we are changed from prasugrel to clopidogrel 75 milligram. But if the duration is delays more than 5 days, then you need to give a loading dose 300 milligram clopidogrel and start 75 milligram maintenance dose. Whereas in the third case, you can see this elderly gentleman who had a CVA with a large MC infarct, who underwent a PCA and had a acute stent thrombosis. So this patient, we are given again a loading dose of, because it's escalating, loading dose of ticagrelor 180 milligram and followed by maintenance dose of 75 milligram and ticagrelor 95 milligram BD dose. So my take-home message after this, my lecture would be that we have to understand the mechanism and action of antiplatelets and the potential drug-to-drug interaction between these various class of agents, and they assess the patient's clinical risk factors for ischemia versus bleeding risk, the clinical setting which the patient has presented, then in angiographic and procedural related factors. And on follow-up, again, risk stratification for de-escalation therapy, like that the previous speaker has shown that a TAP scoring can be done for risk stratification to see which therapy based on the clinical assessment and the cost and financial consideration, especially in our country. Thank you.
Thank you, Dr. Thank you, Dr. Srinivas. That was a lucid presentation of cases, followed by your take on how you deal with antiplatelet therapy, either the escalation or the de-escalation, and you showed us some very good concepts of how to change from one antiplatelet to another antiplatelet in the acute situation as well as in the chronic situation. You also took us through the cases very, very, very nicely. And so now I will hand it over back again to the chair, Dr. Shivan, to say a few words, and we can have a little discussion on all the 3 or 4 speakers.
Hello.
Yes, Sridhar, we are able to hear you.
Yeah.
Okay.
So, can I ask a question to you, Sarath?
Yes.
Sarath, how often do you use the rivaroxaban 2.5 milligram BID dose as in the COMPASS trial? Have you escalated your therapy to that level quite frequently? Are there some subset of patients in whom you give this rivaroxaban 2.5 milligram BID in addition to the dual antiplatelet therapy or in addition to the single antiplatelet therapy, however you may choose, because it was actually decosprin.
Yeah, Brian, let me say I have not done this. The only patients I used low-dose rivaroxaban are those patients who had atrial fibrillation and had undergone PCI for the first 1 month.
That was some time back, I think.
Yeah. No, that's a concept that has been prevailing. So, except 1 or 2 patients like that, I have not used it. This kind of concept of dual pathway inhibition, this is a relatively recent concept. It's catching up. I think today, if you ask me, the one patients whom we can give without much thinking is patients of peripheral artery disease, because these are
those
patients
who have multiple vascular beds which are involved, I think,
who have already,
and those who are very, very high risk also, those who are at very high risk for vascular events. I think we could use that in those cases. Provided the one area which I attended the talk by Dr. Where there was basically a situation where the COMPASS trial was actually dissected, and Dr. Brownward spoke on that about a year back, or maybe 2 years back, and he stated that it would have been nice if they had continued the 5 milligram dosage, because they stopped the trial a year or so in advance. And if they had continued with the 5 milligram BID dose of rivaroxaban, which was not tied up with aspirin, if you noted, it was just 5 milligram BID dose, and may have shown also the benefits. So we could have been on a single antithrombotic agent. However, this is dual pathway, as you can see, and I would like Imad's comments on this therapy, if he's using it regularly, or what does he think about it?
Well, actually, the problem of all the proposed therapies in antithrombotic and antiplatelets is the balance between bleeding risk and clinical benefit. I have some noise in, but anyway, what I would prefer to follow is starting from the risk of bleeding of patient every time. If risk of bleeding is high, I think we should avoid any combination. I mean, we should go for monotherapy as quick as possible. Whatever is coming from trials is just, at least for me, it's just confusing. What is the bottom line in follow-up? That means, should we for how long we should keep that double anti-aggregation therapy? Which kind is the best one? What is the optimal treatment? It is not clear even from all these trials cited today. I would like to ask one of the speakers, which is Dr. Vivek, about Gupta, about the long term. What is the optimal for you? What is the optimal treatment according to your review today?
So, thank you very much, Shemad. We had discussed 2 trials. One was DAPT trial, Another
Yeah,
was,
out of trials, I think what you are preferring in your clinical practice.
in my clinical practice, whenever the patient is not having any major bleeding during the first year, and patient had one or two or more than 2 stents, we are continuing beyond 1 year in my personal practice. If the patient has some sort of a relationship of bleeding or platelet counts going down or something else, or the patient age is more than 75 or 80 years, then I would like to stop within 1 year, but at least 1 year. But we continue sometime lifelong, because the cost of in India, not myself, many times, lot of patients, for example, a patient who undergone angioplasty with 2 stents at the age of 60, 65, we are not stopping clopidogrel unless we have some sort of a surgery or some sort of at that time, or dental extraction or something like, but that is also intermittent. My practice personally, I feel that we want to be safe as far as ischemia is concerned, especially in diabetic population, and the patient is having more than 2 or 2 stents. So when you compare this data from a DAPT trial or the ischemia trial, only you have to stop only when you have a high bleeding risk profile. That means patient has some stroke, some bleeding, fatal or non-fatal bleeding, for example, a GI bleeding or stool in the cord blood or something like that. Then you are forced, or you should stop it. And if you suppose a similar patient has angina, for example, within 1 year, he has another unstable angina, and they undertake another angioplasty or maybe treated medically, I would like to continue even with this non-fatal risk. That means no, if it is GI bleed, I would like to continue, which is controlled. If it is cerebral bleed, I would like to stop it. So we have to really see, especially in India, the cost. There's so many other antiplatelet. If you remember Plavix, in Europe, they were constrained by the cost and by the insurance. We have so many otherwise generic salt available, so the cost is not a constraint. So as such, if the patient does not have a major bleeding and the patient is a high risk or has an ischemia in between, we continue at least for 3 years, even sometime more than that. This is my view personally in Delhi.
Okay, thank you very much. What about anticoagulation, rivaroxaban? Where you will absolutely recommend that? Not you. I am asking Sarat Shandar.
Yeah, that's what I said just now. The one group of patients who will probably definitely benefit, as you can see from both this trial as well as the Voyager trial, is patients of peripheral artery disease, who have diffuse disease of peripheral artery, who have undergone amputation in the past, who have significant symptoms, but not eligible for revascularization. Probably that group has got a huge thrombotic risk. And we also know that they are very prone for coronary events and stroke events. Therefore, I think peripheral artery disease patients clinically are the best cases for long-term rivaroxaban. I would only add that I would rather give a clopidogrel than aspirin, because the major risk of bleeding is from aspirin. And let me just add one more sentence to what Dr. Gupta said, that after 1 year of completion of PCI, if the patient is a high thrombotic risk patient, like what you see commonly in India, those who have reduced EGFR, diabetes, and so on, but at the same time, their bleeding risk is considered to be low, I would treat him with clopidogrel alone or ticagrelor alone, as so much data is coming. In my opinion, it is the aspirin that actually increases the risk of bleeding, gastrointestinal, and probably in combination with other drugs, bleeding. So, you know, if you give low dose, if you give ticagrelor, probably the benefit is as much, but without the risk of bleeding.
Okay. So, Doctor.
Good afternoon, everyone. Actually, the recent data also more supportive of short DAP followed by the monotherapy, like a Twilight trial, Globus Leader trial, and all these trials are short DAP. Even one trial, every trial is showing that just 1 to 3 months even DAP followed by monotherapy with ticagrelor. That is also equally effective in reducing the thrombotic events and with less bleeding complications. I request the panelists to discuss about this issue. Really see the precise DAP score, Paris score, and really score is more in favor of more bleeding or more thrombotic. Based upon that, you can choose. If that is not there, like even ESC also recommended, like is it chronic stable angina, stable ischemic heart disease, ACS, OCABG. ACS, or based upon that we can decide. But now the more and more evidence is there for short DAP, and with monotherapy with the ticagrelor is almost equally effective. Even all the studies are also more in favor. I request the panelists to discuss about this point.
So I'd like to make a comment on that, because if you see at the precise DAPT and the global leader freedom trial and the Onyx 1 trial, they are mainly the high risk bleeding categories where they have been switched, because based on the mechanism of action of platelets, you know that the ischemic risk will be almost down, tapering at the 3 months, and 1 month it is maximum it starts to taper. So that was the basis of switching, because these trials which you have mentioned, most of them had a high bleeding risk categories. So there you can give switch over to monotherapy after giving DAPT for 1 to 3 months and switch over to single monotherapy.
And instead of going straight shot like a 12 months of adaptive, I think better to predict the scores.
Yes.
And like a precise and adapt, and based upon that we can decide.
So if you look at all the guidelines, they also comment that it has to be individualized and
individualized. Yeah, that's right.
Secondly, my concern is stopping aspirin. As you, Sarath, said, that this could be one of the major cause of, one of the important cause of bleeding, aspirin, that means ticagrelor alone. But we don't have any study with the clopidogrel alone. I think we have to start some study where we can continue with clopidogrel alone without aspirin. Secondly, I don't remember how much is the number of patients in the Twilight trial. So that is the only trial which has shown the efficacy of or if overall with monotherapy. I think we need to have, because stopping aspirin is psychologically not easy, especially in the minds of the patient as well as doctor. Sarath, what do you say?
Yeah, just now Dr. Srinivas Reddy showed. Srinivas, what is the number of patients in the Twilight? I think 3,500 or something, is it?
Yeah, 3,000 plus patients were there. And they were all mostly, they're not multi-vessel stenting. They're all like a single stent and low risk patient. They were not higher bleeding risk patients.
I think we have to be skeptical of stopping it. At the moment, I would not like to stop.
But Vivek, let me tell you one thing. I know it is a psychological thing for us that aspirin is the most important agent. If you see
more effective,
more efficacious are the ticagrelor or prasugrel. Of course, they are compared to clopidogrel, not alone with aspirin. But this Twilight study should really make you think in these terms. Complete 3 months or 4 months. See if the patient is a high-risk patient for thrombotic events. If he is not, go with ticagrelor alone. It gives equally, in my opinion, equally good results. 2 trials. That Korean trial also, he has shown, TICO's trial. That also showed equally good results.
More important, bleeding is less in that group. Bleeding is less and equally efficacious antithrombotic.
Equally efficacious but safer.
Yeah, this makes sense. This makes sense. Yeah.
So you have got the TREAT trial where they have compared, there was a comparison between the ticagrelor and prasugrel. So they found that they both are equally effective, but based on the hemodynamic profile and the characteristics, I think ticagrelor would be a safer drug. So if possible, because foregoing the cost, I think ticagrelor would be a better choice of drug.
Now, Srinivas, if you see the recent publication, I think maybe a year back, with prasugrel 1-to-1 head-to-head comparison with ticagrelor, it showed prasugrel is actually safer. Even the bleeds are less. I don't remember that trial's name, but I'm sure you all have read it. We spoke about it many times. It's equally effective and probably beneficial, at least in that trial. There could be different.
Yeah, I'm talking of the TREAT trial, which
that is different. The one I mentioned is different.
You're talking of ISAR-AF trial.
Sorry?
ISAR-AF trial.
Correct. ISAR-REACT 5. ISAR-REACT 5. There is another trial, Prague 18, which came 2 years back, which was done in in Prague. So there also similar results were shown. Equally efficacious. Personally, I use prasugrel much more often than ticagrelor, and I'm very confident to use it. I don't see any excess bleeding complications with prasugrel. Dr. Brian, are you planning to give your talk or you're not?
No, I'm not giving my talk. So you all can utilize this time for discussion. I have a few points to I have a few
Sure.
points to make on this
Go ahead.
particular issue. I feel, and we have been using this, I think, for acute coronary syndrome patients now, I think there is no doubt in my mind that we must use one of the newer antiplatelet drugs. Either we use ticagrelor or prasugrel when we are doing a patient of acute coronary syndrome. And if you have a cost problem, then of course prasugrel is not very expensive, and it is far better than using. I think the only area where prasugrel gives a problem is one when you have a patient who is more than 80 years or more than 75 years of age, has had a TI or a stroke in the past, and those kind of things where it is contraindicated, or the body weight is less than 55 or 60 kg, and then you have a problem. So I clearly believe with a high-risk group of patients, the newer antiplatelet agents are far superior to clopidogrel, at least for using. However, when we thrombolize a patient, when we are thrombolizing a patient, I think at that point in time, the data is much more with clopidogrel than even with ticagrelor, because even ticagrelor, which was utilized in some of these trials, I think it was the thing he mentioned, the treat, which occurred in the South American countries. Ticagrelor was actually brought on board at about 12 hours post-thrombolysis. So I think with thrombolizing, I think clopidogrel is a much better agent and much safer agent with thrombolysis on board. However, taking patients to the cath lab, the newer agents would be far better. From the studies that all have been shown over here, I think we are moving towards stopping dual antiplatelet therapy by 3 to 6 months, and I think that will enter the guidelines in the future with all these trials that Twilight and so many of them which have been shown up, that single dose, that the single antiplatelet agent like ticagrelor or maybe even prasugrel may be better than using prasugrel and ticagrelor with aspirin. As all of you have already pointed out, aspirin appears to increase the bleeding risk in most patients without giving too much more benefit. At the end of 1 year, I think we'll have to really look at those patients who continue to have a very severe ischemic risk and then give the dual antiplatelet therapy only for those, or continue those on a single antiplatelet but not aspirin. It would be a single antiplatelet like either ticagrelor or clopidogrel, depending upon the age group of the patient, the availability, the cost, and so on and so forth. The addition of the antithrombotic, as was clearly mentioned by Sharad, would go to a very high-risk group of patients, those who have peripheral vascular disease, those who have multiple vascular beds which are involved, those who have got some amount of renal dysfunction, those who've had amputations and so on and so forth, or those who are likely to have amputations. I don't think we have enough, though this trial, the COMPASS trial did give us data to suggest that we could use it in a larger group of patients. I still feel that bleeding will be an issue at some point. So I think we now have some strategies we have to balance the high ischemic risk with the high bleeding risk, or the high ischemic risk with the low bleeding risk, so on and so forth, and choose our antiplatelet therapy and our antithrombotic therapy to benefit our patients with the lowest risks that would be possible. I think that's what I would kind of summarize in this particular discussion.
Thank you, Brian.